This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The Motif Experience, where movement and life come together. I'm your host, Dr. Tyler Cuddy-Ford. On this wide-ranging podcast, today we have Dr. Ryan Jacobson, just a big kid, and teaches pediatrics for us here, has his pediatric clinical specialty, and teaches a wide range of courses here. Truly interested in providing the best care in the simplest form for kids with special needs. Well, we have here today Ryan Jacobson. So Dr. J, people call you. Ryan, they call him. He's
I won't take credit for that
he's
either,
a
but I did start
Jack and master of all trades. Mm-hmm. And so I'm master of none. So we're happy to have him on.
You got to lob me a softball
I've
first?
got to lob you a softball a couple times, and then maybe a couple. And then, of course, he's a softball player, baseball player, so I don't know if that gets us anywhere. Where did your interest in peds come from? That's a softball one.
That is softball.
Yeah.
Should I do this like an interview? Like, so I just love George Fox. I love what they're all about.
No.
Okay. Yeah, where did my interest for peds? I was going to be a band director.
I knew that.
Yep.
That's right.
Yeah, I was going to be a band director.
One of the things that we have in common is I actually got a music scholarship. He got a music scholarship. I didn't want to be a band teacher or be a starving artist, and so that's why I declined mine. He decides to do both. So takes the scholarship and
Goes PT.
Goes PT.
Yeah. Oh yeah, I was going to be like my junior high and high school band director. I was going to be best jazz band in the state, all that stuff. And so I was like 2 years into college at Puget Sound, and I said to myself, I am spending way too much time in a practice room. So
By yourself.
Yeah, I mean in the basement of the music hall.
Right.
So I went to my band director, who was also my lessons person, who also gave me my scholarship, and I said, I'm not going to major in music anymore, and I realized this could sacrifice my scholarship. And he said, well, and that's all he really said. But I came back to my lesson the next week, and he said, as long as you still agree to play in all the bands, you can keep your scholarship.
Wow.
But meanwhile, what happened is I was introduced to this idea of physical therapy for kids, which I had no idea. And so I went and spent the summer after my sophomore year volunteering at Mary Bridge Children's Hospital in Tacoma. And it was, dude, I was like, you can get paid for this. This is like playing and science and medical world. And I mean, it was mind blowing.
Yeah. And
so I just, I came back to school my junior year. I'd already missed the undergraduate OTPT prep course, and I went and found the director of the program, Kathy.
Yeah. Dr. Humbleberry.
Yes,
She
Dr. Humbleberry.
helped here.
She helped start this program.
Yeah, for 3 years.
Yes.
Yeah.
So I went and found her up in her office, and I said, hey, I want to be a kid's physical therapist. What do I need to do? And so I just shifted my major and ended up majoring in physics and taking all the other prerequisites. So
yeah. But
all my jobs have been kids stuff, like t-ball instructor, youth basketball, camps. I mean, you can ask my wife any excuse to be a kid. Right. I'm right in. So yeah.
Okay. So then you went to PT school.
Yep.
So when did you? I also did peds, so there's a connection there between you and myself. I was at Shriners.
That's
and
legendary.
Research.
When the students hear that, they're like, huh?
I didn't know. Oh, we'll have to get in that story. So Ryan decides to help us as an adjunct. And that was your first foray into academia. So I reached out to Ryan, got his name from Kathy. And so we had coffee, and I wanted to see if he'd be interested in peds. And so he writes the first exam for the peds course. This is cohort 1. And so he says, take a look at this. And so I looked at the exam and thought, oh, well, this is graduate school, Ryan, and I think it's too easy. And so he sent it out, and students bombed. And it was 100% my fault because I hadn't remembered I was a peds guy. And so all of this stuff kind of came back. And so...
well, you know what's funny about that?
Yeah.
Is I'm only showing up on Monday nights because otherwise I got my full-time gig, right?
That's right.
And so I don't know anything. I grade them by Wednesday, and I come back the next Monday, and the first thing you say to me is, hey, come down to my office. How many times is it good when someone says, hey, come down to my office?
And I'm at the end of the hallway, right?
So, but you owned it completely. You're like, so yeah. And I had already known the grades because I'm the one who graded them. I said, oh, so is that a lower than average score than you'd expect? And you're like, yeah. So, but don't worry, it's all good now. They all passed.
I know, it was great. So that was partly my fault. That was actually really fun. So Ryan and I have a good time together. That is sure. So when did so you plugging away as a PT?
Mm-hmm.
When did you go sideways with peds? As far as this is a little introspection here. So Ryan will explain, I think, maybe what that means. But of course, me being peds as well, a little bit different, I think, environment. So just mostly post surgery.
Right.
So at Shriner, so it's a little different environment than outpatient orthopedics like yourself.
Yeah.
So when did you realize? We've had these conversations with Hauck and Kang, and when did you self-reflect enough to realize that maybe this isn't the best? So you went sideways a little bit, and so talk to us a little bit about that.
Well, I think what happened is, so this is a really good story. My mentor, one of my favorite mentors of all time, good friend Marianne Baston, she's now the head of ambulatory services and multi-care. She was my direct manager at the time, and so I went in for my 3-month review. So I'd been a therapist for a year, and then I changed to work at multi-care, and I went in for my 3-month review. The first thing she says is, so you're really challenging a lot of the other therapists there.
Uh-oh.
Yeah, that's what I'm like, is this how you get fired? That's literally what I thought. Is this how you get fired? I'm like, okay. And I know she wasn't setting me up. I think she just read my face and said, oh, no.
Right.
And what she got at was, like, they were all in their spots doing good therapy in their place.
Right.
And I'm roaming the whole scope of the building and inside and outside. It's not parents sitting somewhere else or sitting watching or out in the waiting room. Like, they're always with me.
Yeah.
Because I'm like, well, it doesn't make sense to me that they wouldn't be. And she says, yeah, it's really challenging some of the other therapists to think about how they could expand what they're doing. I'm like, that's a good thing, right? It was awesome. But I think that was the first, and that came from my first job. I interned out on the peninsula in Washington State at an early intervention place.
Okay.
I was mentored by OTs and teachers and my PT colleagues who we all went out to the real world. The early intervention is about getting out in the real world. And so you're always with the parents because you're going to their house, right? And I mean, it was awkward at that time for me if a parent stepped out to do some dishes while I was working with the kid. I'd be like, okay, we'll come back, how do I say?
Soon.
Right, soon. Yeah, totally. And so that really instilled in me kind of like, I'd want the parents. But I was still at that time doing weekly therapy forever.
Right.
I mean, that was the model in 2000, at least in the Northwest.
So 20 years ago.
20 years ago, yeah.
Okay, all right.
My schedule was a sheet of paper with a Monday through Friday with hour slots. And it was written in pencil, each kid's name, and they got that slot every week.
Right.
And when one was discharged, which happened very rarely, I'd erase it and put the name on a sticky on Marianne's desk, and then she'd give me the next name.
Got it.
Yeah, I mean, it was just therapy forever.
Yeah.
So I think it probably started after I moved to Portland. And my wife and I moved to Portland. We had traveled to New Zealand, and when we were in New Zealand, we'd decide where we'd go after that. And so we ended up in Portland, and I ended up It was fun. I didn't find a job fast on purpose.
Yeah.
I visited like all the peds places down here. Shadowed. I was up at OHSU, went to Legacy, where a friend of mine who was a speech therapist, she showed me around. I ended up landing at an early intervention place again in Vancouver. And I thought I was a parent-centered therapist until I went to this place, which is Pride for Kids. And they're no longer an entity, but they were started by two women who in the 70s each had a baby with Down syndrome. It was 1974. So their boys were born with Down syndrome. And the model at the time was...
So were they PTs?
No.
Just two moms?
Just moms. The model at the time was basically Monday through Friday, 8 hours a day, give us your baby, we'll take this burden from you, and then you can come pick her up or pick him up afterwards. It was like the de-institutionalized institution model.
Right.
And both of them got to know each other through, having had a baby. Both had babies around the same time with Down syndrome. And they said no. And a woman, a researcher from University of Washington, came down when the babies were like 2 months, and they went there.
Sure.
And they went up after her talk, and she said, "I'm staying at this hotel tonight. Can you put me up a little bit longer?" And they put her up for 2 more nights, and they went and worked with her in the hotel. Show me what I can do with my baby. And then this woman came down once every 2 or 3 months. Here's what you can do with your baby now. They put her up in the hotel. The second time, 6 moms with babies with Down syndrome. And so this is the mid-'70s. I mean, IDEA, or the Education for Individuals with Disabilities Act, hadn't even barely started.
Right.
And so this is the place I went into, and I realized, oh, this is a different level of game. And that's when I started to see, putting the family right at the middle of this. Like really at the middle, like we're both on the floor, and if someone walked in, they should think I'm the fun uncle and the mom or the dad is the therapist.
Got it. Like
that kind of, not just, hey, you come in, you sit here, we talk a little, I do my PT thing.
Right.
And it was super impactful. Like it hit me like, this is how parents become empowered. This is how they succeed with their child with some kind of disability. So by the time I was done there, I mean, I had to wrestle with the idea of why am I seeing this kid weekly when they just learned to crawl and they love getting around.
Right.
We'd come back in, we'd play crawling games, we'd climb over things. I mean, we'd have all kinds of fun.
Right.
But
it's the same thing.
It's the same thing, and the kid has no readiness to try something different. Right? They've just found mobility. They love it. I mean, yes, for the hour that we're together, we're doing things that take strength and resistance, and we're, if they're trying to stand up, we're trying to get ahead and get them some experience doing that. And, if I'm doing my job well, mom's coming up with ideas, dad's got ideas, and we're bouncing ideas off for what the rest of the week would look like.
Yeah.
But a lot of it is kind of like you're also paying hundreds of dollars insurance-wise to do this, and do you need to be? And I don't know if the pediatric field at large has gotten to the point of asking that question in a way that really means, what if I'm not needed as much?
Yeah.
Now I know for sure, national and international leadership in pediatric physical therapy, they're on board,
Yeah.
But I don't think in the day-to-day that most of the pediatric PTs or OTs or SLPs out there are really asking it in the way that would come to a conclusion that I'm probably not needed as much for this.
So it wasn't really a journey then for you of just practicing and then realizing, all right, so this not working. You talk to myself or Kang or how cracking 80 times a day and realizing really, am I really making a big difference? So it wasn't that per se.
No.
That got you to think differently about how to practice with kids.
No.
Just initially you thought, why or how can I give them the best value? How can I empower families? So that was your lens.
Yep.
How can I empower families so their kids can have PT all the time?
Right.
Not just once a week even, okay. So fast forward. So you're dabbling in peds still, and just finished a clinical practice guideline. So congratulations on that. And is that out, or is that just in?
So a paper that contributes to it.
Oh, paper that contributes.
I wasn't on the CPG.
Oh, okay.
We took the CPG and we analyzed its ability to basically predict how much PT you'd need. I shouldn't say predict either. Associate less severe needs less PT.
Oh, so yeah, tell us about that.
Okay. We took like 3 years of every patient who came for torticollis at Providence.
Yeah.
And we looked back and we basically ran stats on when were they seen, how early in life, how severe was their rotational deficit, and then use those factors to determine that, at least for the young kids under 6 months, that the later or more severe, the more likely you were to use more PT over a longer period of time. And so retrospectively, that confirmed what the clinical practice guideline had laid out an 8-grade severity scale. And it basically confirmed an association between grades 1, 2, and 3 as you get more severe, needing more PT.
Yeah.
Which is really good for backing up why, our pediatrician and family practice partners, why it's worth their time to get that referral the first time they see the head
something
tilt.
off. Yeah.
Because they'll need less resources overall.
So what were some of the numbers then for how much?
Oh gosh,
do you remember it all?
No,
he does. He's a numbers guy.
No, I don't. I don't actually remember the numbers.
Okay, all right.
Yeah. No, I don't remember them at all.
No, that's all right. I just thought maybe something stuck out about if they're,
no, it was more the trend that stuck
like
out.
3 or 4 treatments is really all they need at at this level.
No,
okay,
no.
All right, that's right. So your peds is not over,
no.
But so how does Promise play a role in what you're doing now? So for those that don't remember, patient-reported outcome measurement information system, which is
awesome. No, I'm just kidding.
It is awesome.
It is awesome. It's. I don't know. What do you want me to tell you about it?
Just for those listeners,
what is
it?
So, it's probably the most rigorously validated and developed version of asking the patient their input on their own ability to function or their own psychosocial domains or their physical health, get their own thoughts about it in an objective way that actually pans out to mean something for care. So it's an outcome measure.
Right.
And, whether it's your own appraisal of physical function, your own physical function, or your ability to really participate in life, like there's scales in Promise for all of this, and they're all it's brilliant. They are all normed for the most part to the general population in the U.S.
Yeah.
Not about like patients with knee pain or kids with CP.
A specific disability. So have you applied it to peds?
We're just starting to.
What does that look like?
So in the literature, what it looks like for the most part, kids with very specific medical conditions like arthritis, juvenile arthritis, cystic fibrosis, hemophilia, things where the condition has a relatively focused medical presentation. Beyond that in literature, there's some people who've looked at, well, how would this function for someone with cerebral palsy?
Yeah.
And that becomes a little more clouded, I guess you'd say.
Yeah.
Like how do you ask about...
Yeah, give us an example.
Yeah. So let's say you have a child who's 8 years old.
Yep.
And she has cerebral palsy,
yep.
and she walks with a reverse walker.
Yep.
And then you administer a mobility questionnaire that was normed to the general U.S. population, but that sample didn't include people with significant physical disabilities, right? And so the questions asked quickly get into like ability to get around and stuff. And so inevitably, that child with cerebral palsy will score 1.5 or more standard deviations below the mean. How helpful is that? That's different than asking a kid with juvenile idiopathic arthritis who, when he or she has a flare-up, their physical function, their mobility scores go down, and then when treatment comes in and they get back active, the scores go back up. And that's the different part. Like cerebral palsy it's something that happened once prior to around birth.
Yeah.
And then over my next 18 years of childhood, I'm expected, this girl with cerebral palsy will totally make gains, but it's only going to diverge from what's normal or what's average. And so what we're starting to explore is what's the utility of promise with these kids who have kind of these long-term consistent disabilities. And there's no answer out there. I mean, there's other people looking at it a little, but I think this is a question of its utility and value for those kids.
So people would be able to find that if they searched?
I would hope so.
You would hope so, okay.
Yeah.
All right.
Uh-huh.
So, but as you're talking, isn't it the same? So let's say fast forward little Susie. Now
Mhm.
she's 18,
Mm-hmm.
right? So no longer a kid.
Mm-hmm.
She does the same thing. She may or may not have a couple surgeries along the way,
Right.
right? So it might be loft strand crutches,
Mhm.
maybe a little bit as you.
The little forearm ones.
Yeah,
that have
the
cuffs,
the
yep.
little forearm ones. As
Yep.
you get a little bit older, you want a little bit better mobility, maybe if
Mhm.
she's able to, keep her mobility up as a
Right.
teen, and
Mhm.
keep her health strong as a teen.
Right.
How would she score?
She'd still score low,
Right, standard deviation and a half.
and at least.
Right. So to me, that
Mhm.
says that's still a perfect measure, because you're still capturing that person, even though there's no improvement.
Right.
She's still as a a young adult, with
Capturing what she's able to do.
capturing what she's able
Absolutely, and actually, that's probably the value it's going to have is
Okay.
relative change for an individual.
to do. Right.
And we're only talking about physical function.
Right.
So one of the beautiful things about promise is I can hand the child or their parent an iPad, and in less than 5 minutes, they've filled out 6 different psychosocial or physical domains. So right now in our clinic, we do physical mobility, upper extremity function, fatigue, peer relationships, cognitive function, and positive affect, which is like the inverse of depression, basically.
Right.
So in 5 minutes, I can know all of that.
Right.
Now, a lot of people would think, "Whoa, Ryan, like that's a lot. I'm a physical
That's way
therapist.
too much to handle.
Well, I'm a physical therapist, right? And
Physical is the first word in our
yes.
profession.
However, I will also say that at least as far as all my PT colleagues in the Northwest,
Yeah.
to be a pediatric PT, we are already living in all those realms,
Right,
right? You
right.
know, like we don't just treat the child's physical function,
Right,
right?
right.
That, all the things that bear on a family in their life related to having a child with a disability,
Right.
and all the other stuff that comes along does not stay outside the clinic, right?
Right.
So I think what this is giving is the opportunity in 5 minutes or less for me to objectively measure these things that I might or might not have a good idea about.
So how does that relate to adults?
Well,
The psychosocial domains.
see, I've always thought I would
Yeah,
be a
go.
very interesting therapist in an
Adult?
orthopedic
Okay, all
clinic.
right, yeah,
I
yeah.
think I would be really. I don't know if I'd get fired or if people would look over and just say he's a weird one, but you should work with him. Or,
You'll still get better, but he may ask you weird questions.
well, and like how I could never picture myself like doing sports physical therapy without taking all this into account.
Okay.
And I'll be honest, like when you think about like when I first came here, and I was describing to Dr. Hauk, like what life in pediatrics is like, and I'm like, yeah, I love it because there's the physical stuff, and then I'm thinking about the family, I'm thinking about this, and I'm trying to decide what goes into what. And he looked at me and asked some version of this question, like, so how do you know what matters? Oh. I don't know. All I've done is formed my own opinion about what
Yeah.
I think matters. And if
Right.
I'm honest looking back, confirmation bias said whenever I saw it, I knew that, hey, I've got this family. It looks like mom's a little disempowered. I bet her self-efficacy is low, or however I thought about it. I just used my own intuition.
Got it.
And I don't think that's really objectively accurate a lot of the time.
I think that's true.
I think
yeah.
Dr. King forwarded us a study because he
yeah.
just likes to throw us papers.
He does, yeah.
And maybe you saw this one too.
I did see it, yeah.
Physical therapists in adult practice were only 40% accurate at
Right.
determining their patient's self-efficacy level.
Right.
That's probably me when I was practicing
yeah.
full time. Was like, oh, I got this. I can totally tell.
Right, right.
So it turns out, I'm here. We've got our on-site clinic. So one day, boy comes in, his mom, who's 12, microcephaly, kind of like cerebral palsy, and lower cognitive and communication function. And so I do this battery of those six promise measures, and I get it back, and the peer relationship score is a standard deviation above average for kids his age in this country. Now, here's two things that happen. One, I feel guilty because I assume because he has low cognitive function, poor mobility, that he probably doesn't have many friends.
Right.
That's terrible.
Right. Right.
But the other thing is, I need to understand more about this. Like, I need to.
Got it.
So I asked his mom. I said, "So, here's how this works. It looks like life with his friends is great." And she said, "Oh, everyone loves him. He's got these two close friends. They do everything together." I think that's been happening in my practice for 15 years.
Yeah.
The first 15 years easily.
Without recognizing
it. And because I can't measure it.
Right.
Right? I love, like Dr. Houck says, we are what we measure.
Right.
And that's real. That's not just like a cool catchphrase. That's kind of like, if I don't know what I'm measuring in practice, or if I don't have a good objective measure for that, I'm really shooting in the dark. And that's not to discount our intuition or our clinical experience, expertise.
Right.
But what I picture happened with me is selection and confirmation bias. Over time, though I'm gaining experience, I'm starting to look through a lens that I've created for myself. And so I'm only seeing what I know to see.
Right.
And so promise is cool for its potential for that girl who's 12 or 9 with cerebral palsy who's walking with a reverse walker.
Right.
To get into more objectively, how am I in my part in her world impacting like her full existence, like her ability to participate in school, in life, her social relationships, the way she contributes value to the world. Kids by easily the age of 6 or 7 already have some aspect of them about their purpose in this world. Now, it's not like we would say, "Hey, little Tyler, what's your purpose?" That's not a thing.
Make mud pies and
right. But in the same sense, there are ways that translates to what they're trying to give and what they offer to the world. And if there's one other thing that promise is, I'm hopeful that it brings out, is some kind of at least indirect metric of the way a child with a disability contributes to the people around them.
Yeah.
And I think that's profound. We'll see if it pans out, but I think we don't stop as humans being satisfied with being happy. Like, we at any level, in any situation, always look for purpose or who we touch or what we give to the world, not how we're all helped. And I think that's cool.
That is cool.
So.
And you're right. I think they do get a sense of purpose early. And so whatever influences that, because I can remember when I was little and wanting to do something significant.
Yeah.
So I was 8 years old. Here's the story. And I wanted to make the longest bicycle skid in the world. I wanted to make the Guinness Book of World Records, right? So it came out. You're a little kid. You're reading some of these, right?
I think there's going to be blood involved.
And so our cul-de-sac has a little bit of a downhill, so I'd ride at the top, and I'd go as fast as I can. And I slam on my brakes, and so doing this a number of times. And a neighbor boy was watching, and says, "Well, what are you doing?" And I told him I wanted to make the longest bicycle skid in the world, and he says, "Well, I can help you." So he brings his motorcycle out and a rope, and he's attached my handlebars to the back of his motorcycle. And he says, "All right, so we're going to go fly down this road, and when I say now, I want you to slam on your brakes." Sounds easy to me. So sure enough, flying down slammed on the brakes, and it popped the tire in just a second or two.
Blood.
So just blew up the tire, tipped over, rolled over into the ditch, and then he left. Right. So and I was, like you said, I was all beat up, and so there was purpose.
Yeah,
there was purpose in
That's
that
so
when
funny.
I was 8. I think people think that that's what happened. That probably did.
Right. It could have something to do.
It could have something to do with how it turned out.
I feel like you're a bottomless pit of these stories.
I do have a lot of stories.
You know, we draw a lot of similarities between us, but I think one difference is I was a kid who, when we built the little skate ramp, was the last one to try it after I knew it was safe. I think you were the one who tried it before there were nails completely
Probably,
in it.
yeah. That is true. I would build skate ramps and bicycle ramps, and mostly bicycle ramps.
When it was time to learn to go off the curb, I had to go find the little curb driveway that goes into the grass first.
The little first one.
So I could fall in grass a few times.
That's good.
Yeah.
So where do you see yourself?
Usually in the mirror.
Okay. So good. Thank you for that. No, as you're plugging along here and dabbling in research and doing a number of different things.
Yeah.
Where do you see yourself? Fitting.
I keep asking this question.
Okay.
Yeah.
Say some of the podcast is personal. So
that's okay.
It's a motif where movement and life come together.
Yeah.
So that's you talked about what matters, and in our world, what movement, because there's movements that matter, and there's movements that don't matter, and and life matters.
Yeah.
So so little we're going to get personal here a little bit.
Absolutely. All right. So when I was at Providence. As a full-time supervisor, that is.
Yeah.
There were parts that were filling.
Yeah.
I now understand what those were, and there were parts that were management that was just like, that's not what I need in my life.
Right.
But when I was there, I started my own private practice, community and home-based. I wanted to get back into the home.
Wow. This is a new story.
It was an LLC.
Yeah.
It was an LLC that landed me with the Oregon Director of Rehab in 2 different meetings to make sure I wasn't internally competing with myself.
Yep, there you go.
Which was fine. We weren't. But when I decided to just leave the supervisor position, go on call, I had resolved that I would never work for a boss again.
Oh, wow.
Yeah. I was not... This is what drives me on your question, where do I see myself? Like, I keep asking, where am I now able to contribute at another level?
Yeah.
Like, God has given me a lot of gifts, and, the circumstances of my life and my family, I mean, there's a lot. I just want to keep doing work on behalf of people.
Right.
And I love it in pediatric therapy because it's everything in life is on the table for those kids and those families. Right. So
how do you get that across? You did a poster just recently.
Oh, yeah.
And presented it at a national meeting.
Oh, yeah.
And
yes, I did.
Yeah. So what happened?
All right. So my poster was it was called "Less Physical Therapy, More Physical Activity."
Right.
No, more physical participation.
Right.
Meaning, we as therapists need to get out.
Right.
And find ways to facilitate participation. And so we had done for a year here in our clinic this model where the family comes in with a kid, and the initial discussion isn't about your typical subjective exam, right?
Right.
I mean, it was about, like, what's on your plate right now that you really want for little Tyler, right? Or if Tyler's old enough, like, what does Tyler really want?
Yeah.
And the goal of the eval is to figure out what that one thing is, figure out what we need to know from a physical therapist perspective about it, and then make a plan. And literally the plan is to take the 4 or 5 DPT students, our graduate students who are in that eval, meeting this family, being part of this discussion, and then after that, make a plan of them going with the parents and the child somewhere in the community. And, climbing at the gym, a little girl who was afraid to get off the floor more than a foot.
Right.
In 6 weeks with those students and the parents really getting into it, was climbing 2-story climbing walls.
Right.
I mean, so the poster's about that.
Right.
And it was a special report about, like, how we run the clinic and everything. So I'm standing at the conference, and there's posters here, and then the posters are next to each other, but over on a table is a poster and some techie, cool, crazy looking stuff. And I look over there and people are crowding around it. And I think I had 7 people who talked to me in 2 days about this idea. And the 7 people who talked to me are like, I left pediatric therapy because no one's doing this. Right? Like they were bought in. But I look over there and there's crowds of people and they're talking about using primitive reflexes in rehab in order to improve movement performance. And they've got techie looking stuff and stuff.
Oh, sorry.
And
Sorry.
I mean, it was hard because I'm just standing there going, you're all drinking the wrong Kool-Aid. And
wow.
I'm going to say it, you're drinking the wrong Kool-Aid.
Yeah. Yeah, I think that's fair.
Not from a place of ego, from a place of what the science says.
Right.
Right? It was 25 years ago plus
Yeah.
when, the leaders in neuro and pediatrics started abandoning the idea of like primitive reflexes and inhibitory movement and stuff that we at once held dear.
Yeah.
Right? There's an evolution. That was 25 years ago. And
Right.
this was last year that I'm there. And it's not, I think it still pervades what we're doing.
So I was going to ask, is it coming back, or is it just kind of?
No,
it was there for so long and embedded, and it
is.
just have moved up as
Yep.
yeah.
Yeah, and when we go to CSM, American Physical Therapy Association, combined sections,
Yeah.
right? Like nothing there. Okay, I take that back. Nothing there being done by anyone who's leading in our fields has anything to do with that anymore.
Right.
I mean, it's current motor control and motor learning theory, how it's being applied in different populations,
Yeah.
Rehab versus habilitation. I mean, and everything that science guides us towards what we need to do with kids with these diagnoses and these diagnoses. It's like, it's there, but we're not buying into it in practice. And even though there are therapists in our community and even in the greater Northwest who are,
Yeah.
the overall framework and even some underlying assumptions still come from 50 years ago.
Right.
And that's not leading to kids getting out and participating in their world better.
Right.
Right? It's not leading to kids contributing to other people in their world or to
Right.
great work that they can do.
Right.
Right? It's I don't even know if we can argue it's doing much long term for basic physical performance.
Right.
And that's hard because that's where we were.
That's profound, really, to think in those terms about what if you did nothing, where would they be?
Right.
What if you did that once a week for 18 years? Where would they be?
So I have our students are pretty amazing. That's a fact. So this is not an uncommon discussion, but one student last week pulled me aside and said, so here's what I'm wrestling with. You're saying that our interventions should be out participating in the world, taking that girl to the climbing gym with her family, finding resources for them to do. So I'm struggling with, why am I even needed as a PT? Why not a coach? On the other end, this person's struggling with, but I have something to offer, and it's the physical stuff. It's I can analyze balance and gait and motor control and so why can't my interventions be balance, strength, motor control interventions? Well, that's a good question.
Right.
That's what we should be asking.
Right.
The most recent clinical practice guideline that just came out in pediatrics is for developmental coordination disorder.
Yeah.
It identifies no evidence that an intervention at the body structure and function level, at the impairment level, will do anything to change the trajectory for a kid with developmental coordination disorder.
Right.
It does identify some reasonable evidence that if you combine power training with task-oriented training and actual doing what you want the kid wants to do, like participating in the real world, doing the real sport I want to learn, et cetera, if you combine power training with that, you'll see good effects.
Right.
But that's the extent of it. And yet we still think that if I make you stronger and I make your balance better as a kid with CP, that will up-translate to now you can hang out with your friends or keep up with them at school. Or,
Right.
And it doesn't. I mean, I say this to students because students come with a perspective of the outpatient orthopedic clinic, right?
Yeah.
I said, so I want you to think about what you've seen as far as physical therapists, because we know that I can go in for, let's say, Achilles tendinopathy, and that patient's not able to participate in sport, and I can do evidence-based interventions that are all impairment level interventions. It's high load strengthening. There's some basic pre-sport training, and they can get back. What we don't acknowledge is that something happened on the patient side that got them back into sport.
Right.
And it wasn't the fact that we made them stronger. It was some asset they had that either we did as a therapist or did not steward. And many of us as therapists never steward it. We just assumed, I do these strength exercises and they get back. And the ones who don't they didn't adhere, or there was some other reason. But in reality, and in pediatrics, and it's looking like in many adult neuro populations, just providing an improvement in an impairment level problem like strength, power, balance, is not automatically going to translate into ability to do activities I want to do in life better.
Yeah.
The best part is there's prevailing opinion with a little bit of evidence behind it that doing participation and activity level stuff will actually also improve strength and balance. And the opposite. Which, if it does, that's a bonus.
Right.
But what does every patient who walks in the door want?
Difference does it make?
Right.
And
even
at
all
the end of the day.
Yeah, patients who come in with pain in an adult clinic.
Right.
Patients who come with pain, even though that's all they're focused on, if you ask them their goals, my goal is to get rid of my pain. Honestly, if you can dig in more with them, I want to get back to X or Y or Z.
Right.
And why shouldn't a therapist use things beyond just what we do in the clinic to get that patient back there?
So we went always full circle back to promise.
We kind of did.
That's interesting. Yeah, the patient report matters.
Absolutely.
So, how does this work in Africa?
Yeah. That's a good question.
So Ryan's led teams to Uganda now for 5 years or so, and so revolutionized how we train and teach and behave in Uganda. So tell us a little bit about the trips, and they can watch the video online. But but so just in a nutshell, how does your work, your current work, future work, relate to the same kinds of ideas in a whole other country?
Okay. I think it's fun. One thing we look for as therapists is just the answer for a patient.
Yeah.
Like, what is the solution now? And if there's anything about practicing pediatrics, it's you're going to spend longer time walking alongside that family. And so thinking in a journey perspective is valuable, because what might impact things early on in the journey are not effective later, and vice versa.
Right.
So, the first year before I went to Uganda, when you and Dr. Haupt went with the students, the biggest impact that happened when we came back the next year is the school we worked with, which is it's a school of 80, 90 children who live there all year. It's only kids with disabilities, the hardest behaviors, the biggest physical disabilities.
Both physical and mental.
That you would never even see in the United States. And really run down. There's a really nice they're both public schools, but there's a really nice public school just down the street that you're like, there's not equal resources happening here. But the biggest impact that happened from year one, when you guys went to when we came back, was we came back and the kids weren't sick, and the kids weren't runny nose, and their uniforms were cleaner, and the whole physical space was upkept, and there was a different sense of pride in what they did. And all that we can imagine when we talk about it is, hey, someone else came and invested with us in what we're trying to do here. And probably, which we know with service work, these are doctors of physical therapy. So there's a high level of professional training that, especially in Uganda, was valued, right? And that's not to say like, ooh, we saved them, but rather like that first year, I remember you saying at the end of the trip, you'd been all kinds of places, and you asked the students, like, where do we need to return to? And you all agreed it was Chirika School, because that was where we could be a part of their equation, you know? So that was the first year. What happened in the next 2 years was we did a lot of physical therapy.
Right.
Right? What changed was not a ton. Like we built our relationships a little bit, you know, with the teachers and the caregivers and the director there.
Yeah, yeah.
And our students were out working in pairs with a kid, and we came back the next year and it's like, what's really changed? And so then we said, well, who's not out there with us? The teachers and the caregivers. And so then we shifted. Let's do this side by side. Let's do physical therapy with them here. Meanwhile, let's make sure that we're hearing what they have to share.
Right.
And in the next 2 years, what happened is some of those teachers and caregivers felt they had a new tool. And we'd come back, and that's when we'd have the stories that come back. Last year he was in a wheelchair. This year he's playing soccer on the field. Like,
Right.
It wasn't because we were there for 2 weeks. It's because, you know, Grace worked with this kid to play soccer every day or did these exercises, right? And so we had already shifted to, this isn't so much about physical therapy as it is about empowering the caregivers. And that was great until we went in the 4th or 5th year, and they're super under-resourced, the teachers and the caregivers, and they were full. Like, they couldn't do more. Right? That would be dumb to ask. And so when we went back the last time, which is over a year now, in 2019, we resolved that we weren't going to be about physical therapy anymore. We were going to be about what they were about. Yeah. Now, that's a big step. And we had to walk with the students who, you know, when you're a student, you're like, well, I'm going to Uganda to do physical therapy. So we walked through with them the experience and what we were seeing. And we'd even the year before done a study, and we even had Katie Porter stay longer and get more input from them about how taxed they are. And so we went in not to do physical therapy in that school, but to come alongside the teachers in their classroom, in their class activities, and actually to put ourselves in a place of the learner, which melded beautifully into, like, in almost every situation, like, hey, we both have something to share here. And all of a sudden, the teachers were the center of the deal. Now, it's one thing, you know, in any area of practice where if I, as a physical therapist, have the parent alongside me and I'm empowering them to do physical therapy stuff with their kid, I think the next level is for me to come alongside them and be whatever they need me to be in order to get what they want from their child. Right. And I think that's how it translated. And in that sense, I think that's the shift that we need in pediatrics in general. Because when you walk into an outpatient pediatric clinic, you're there for physical therapy. Yeah. And the assumption is that the therapist is an expert. And so even when Ryan, who loves to have the family side by side with him, invites them into the session, they're still looking to me for some answer they think they don't have about their kid's life. Right. And I think the shift that's going to create changes in outcomes beyond what we get right now is going to be, I'm about what you're about. Dr. Kang says this, like, when a patient says, this is what's important to me, I want what you want. Right. And this, you know, we teach this in pediatrics. The students say, so if you see glaringly that the child needs this and needs to start walking and the family is not about that, you don't work on that? And I say, no, I don't work on walking. How can you not work on that? They need it. They're 3 years old with CP and they're not up on their feet. I know. What do they want right now? Well, you know, he's playing wheelchair basketball or he's doing this. Like, argue for me that me forcing my priority on that family is going to be a better long-term outcome than what they're all about. And so I think, you know, whether it's promise and understanding a family fuller, using promise, all those domains to really start conversations about something that you can measure, and then getting deeper in what the family needs, or whether it's just our perspective on how we do therapy, right, in the clinic, or, you know, what happens in school-based therapy, or what happens in early intervention. Like, where are we putting ourselves as the therapist? Whichever way you do that, I think this shift could be valuable. And I feel like with what limited evidence we have in the world of motor control for certain populations of kids, that it's tending us towards participation-based interventions, towards
Right.
task-oriented interventions, towards things that are specific in context, not in my medical-based clinic. Not even in my George Fox school where the kid doesn't spend time otherwise. And
Right.
so I think there's something there. And I'm happy to push for it because I have time.
Right.
I'm not doing the full-time grind, which for a pediatric physical therapist
It's hard.
it's
Yeah.
comically hard.
Right. Right.
Because even from a perspective of a high-volume outpatient orthopedic adult clinic with an 85 or 90% productivity rate, to hit a 70% productivity rate in pediatrics is another level because it's families and
Right.
it's life.
It's not just a task you're having them do in the clinic.
I mean,
Right.
I think if you depending on where you're at in the state, 55 to 70% of your kids are on Medicaid, which means they are at some poverty level.
Right.
Right. So there's their resources. You're asking a family with 4 kids to get here at 1 o'clock for an hour thing.
Right.
One of them should be napping. The kid you're working with hasn't eaten because they wouldn't eat in the car.
Right.
Is the parent in a space even to
Yeah.
work alongside and learn and grow together? I mean, there's just a lot to what we do, which I would consider low value.
Right.
And if we think of what like the triple aim or the quadruple aim
Right.
is, how much patient outcome can I get at a minimum amount of resources that maximizes population health and also doesn't drive our therapists to early retirement?
Right.
So there's just so much there that we could embrace. Yeah.
That's I think we'll stop there. That's profound. If you think about how just PT, just even outside of peds, we've been talking
Mhm.
about peds for an hour.
Yeah.
But that last comment was, doesn't that, it shows us where our values should be.
I don't think so.
And not necessarily in a particular back rehab modality, right? Or
Yeah, yeah.
not in a particular joint mobilization or whatever it might be. It's it may be just that simple.
It could be.
Looking at that patient in a better way, more holistic way, and finding out what matters to them.
I would say this though. I have not met a pediatric physical therapist who doesn't have a heart for exactly what
Right.
you just said.
I'm with you there.
And you've been in it too. Like,
yeah.
you don't go into pediatrics for anything other than I want to serve kids.
Right.
But I wonder if the history, the culture of our workplaces, the demands of healthcare, and other things are keeping us a bit shackled.
Yeah.
People ask me, like, what is the one thing you would change to move things in a direction like you're talking about, Ryan? And honestly, I say,
That one thing.
stop paying me for the time I spend with a kid. Start paying me for outcomes.
Right.
And if I don't get the outcome, don't pay me.
That's we are going to try that model. Not try. We're
Mhm.
going to do that model in the new, as we grow in the new clinic.
Yeah.
If I'm not getting, why are you paying?
Right.
So I love that model. Let's put your money where your mouth is, because our intervention should matter. And if they
Absolutely.
don't, then why are we getting reimbursed?
Imagine, like, I work with 9 or 10 other really amazing pediatric physical therapists. One of them is George Fox grad. I work at Providence. Every one of them would embrace this.
Right.
Because what it would do, it would say, finally, I can use telehealth because I don't need to see this patient all the time. Or
Right.
finally, I can leave the constraints. Like, I won't get my hand slapped if I go out to a place
Meet
where
him
the
at the
family
park.
Yes. Or
Right.
yeah, I think right now with this kid, I need to see you every day for a half hour.
Right.
Because this is so important right now. We're going to get this done and
Right.
figure it out together. Or I could say, hey, Mom, you can come back and you don't need your kid.
Right.
Right? Just let them play at home with
Right.
whoever's staying at home with them.
Hey,
Let's
I've
take
got
some time with you.
Yeah, I got some ideas on.
Yeah.
Yeah.
Or whatever they need. Because
Yeah.
then the only metric for, let's face it, what drives how we practice is how we're paid.
Reimbursement. Yeah.
Right? Absolutely. And so what if reimbursement was who's the most creative, who's got the best ideas, who's using evidence best, who's willing to take what is good with what we have and throw out all the rest.
Yeah. And then
that'd be fun.
Who's getting their patients better?
And I'll tell you how many there are. They're the 7 people who came up to my poster versus the 20, 30, 40 who went over to the other side.
Yeah. To buy a widget.
To buy it, yeah, exactly.
Yeah.
So I think that's where we need to go. And that's, I think when you ask me, like, where am I going in the future?
Yeah.
That's what I want.
That's cool.
Yep. Yeah.
I mean, I'm surprised that, but I shouldn't be surprised. The PEDS world's no different. Right. So meaning trying to figure out what those things are that are most important. Mm-hmm. And then capitalizing on those to get someone as good as they can be.
Yeah.
Yeah.
Remember I said I would never work for a boss again, and here you are, my boss. I had to come to terms with that. However, I think it's a value for our Northwest pediatric therapy community that me and Dr. Bompiani over at Pacific and whoever lands at OSU, that we do have the time and bandwidth to help our community get here.
Right.
Like, because I've done the full-time productivity thing in the clinic. You don't have time to breathe. No. Like, much less change practice.
Right. So we'll put those references that you talked about. We'll
cool.
give them a link for those to be able to read those. You mentioned 5 or 6 studies, so
yeah, you'll have to like find them for me.
we'll
find them on the recording so that I can just say, what did I talk about?
No, I know we will.
I'm not Dr. Hauk where I just say, yeah, in the Vanderkamp 2017 article. Blah, blah.
Yeah, so I was in we read the same articles. How can I do? So because our research was similar with behavior of the knee. And so his happens to be in ACL deficient limbs. Mine was in running population. So we read much of the same, and in
your PhD.
In the PhD, sorry, at Iowa. So we had file cabinets full of articles, and there'd be times when someone would, bring up a question, and this is how Dr. Hauk would answer. Well, in 1989. Dr. Shelbourne in this particular journal, who's from the University of Colorado, did this research. And it's like, wow, well, we read the same article. I didn't get that out of it.
Absolutely. It's so true.
No, that is true. Yeah. Thank you, Ryan.
Thank you. That was fun.
Wow. Great topic today. Great conversation today. Thanks for listening. Thanks for tuning in. And just make sure you're connecting with us in some way, whether it would be, liking or subscribing. You can connect with us directly, and be sure to visit our website, motifcenter.com. And if you want to be featured in our Q&A, send us a question. We'll be happy to answer that in our Q&A session, and let us know where you're coming from.